Now, this professional graduate designation is a real problem. The $20,500 a year is not enough. The $100,000 may be enough, maybe not enough. And it's not just for us. Physicians have a problem too, right? If I'm a physician, I'm taking out $300 in loans, and I need $70,000 a year. Well, now I've got a problem too. So again, the problem is the PLUS loan going away.
Kick it.
Hello, welcome back to Strata Stories. Today, you will hear from Dana Strauss, a PT and policy health expert. In this two-part series, Dana's State of the State breaks down the most important federal programs, models, and policy shifts affecting rehab therapy today, where new reimbursement and revenue opportunities may be emerging, how therapy can better provide its value to CMS and shape future payment models, and what this means for clinicians' purpose, practice sustainability, and long-term profitability. Let's get started. We'll say there is kind of a mentality in the physical therapy sphere where a lot of people are mad at the reimbursement.
Yeah.
And I don't want to call it a Band-Aid because it's not a Band-Aid, and in many ways it's still good, but people just immediately do cash-based services. But again, I have seen that before where you were talking about from a demographic societal aspect, you're talking to the haves and not the have-nots.
That's right.
And the
or
problem
even the
is
medium halves. Not
Yes,
a lot
the
of people are
medium.
willing to pay for care out of pocket.
Yes. And unfortunately, is if you look at population health, we're not doing very good. In fact, we're doing worse. And there's, depending on which study, most of us were going downhill.
We are.
And so this is something that from a dollar spend, and you know that people are looking for other ways to get healthier. Most people don't want to go to the doctor. That's why supplements is such a big industry. But it's like, how do you change the main care industry of medicine to include us, to make it seem more functional and holistic, which we are. We're not just, therapy allows you to move your body and see great aspects, but I just see it so frequently. But here's my question. There's that mentality of we're not getting paid enough, and my doctorate degree is so expensive. But now we're kind of in the survival mindset.
Yep.
And when we're in the survival mindset, we're not taking the time and investment to make these changes. So what would you say to like this newer generation of therapists, and now with, even changes to, something they call it the professional tag.
Oh, I'll tell you about that. Yeah.
Let's talk about that. Like, how do we get out of that survival mindset, especially with changes with DPT programs and loans, so that we can eventually get paid more?
I love that you framed a survival mindset. And that's why I don't treat now. I couldn't afford it. And I didn't even have those kinds of school loans. I graduated 1 million years ago. I paid my school loans and they were a fraction of what everybody's got now. Ironically, right? Reimbursements really not any different. Like what I was making back then when I even stopped treating is not that different from what people were making 15 years later, right? So yes, survival mode is scary because I've been in survival mode in different areas of my life over time, and you're not able to think broadly because you are trying to survive. Trust me, I have complete empathy for this, right? It sucks. When you're coming out with $150,000 in school loans and you're making $90,000 a year, it does not work. It does not work. Like there is no solution that's going to make that okay. What I hope we can figure out is how do we bridge? There are solutions, very possible. What I'm describing is very doable. We can make the case, we can present it, and we can demonstrate how we are not being utilized, why, and what the fix can be. Changes can happen through that. This is how change happens through regulation all the time. But I do worry, to your point, that we're so focused on surviving, our brains can't wrap our heads around things could be better. Before I talk about the loan issue, let's first talk about the facts. Professional status has been in statute, so in the law, on the Code of Federal Regulation for decades. Professionals, for the purposes of loans, have been categorized for decades. just to set the record straight, we were never on the professional status list, okay? The list has been the same list all this time, right? It's not just used for loans, it's used for a handful of other federal purposes through the Department of Education. There's a laundry list of them. I wrote about it in my newsletter. It's also a blog on timeless autonomy. I went into the details of this. But suffice it to say, none of that is new. Okay, we were not considered professional. We were considered graduate. That is a random naming. It makes us feel terrible. It makes nurses and nurse practitioners and lots of others feel terrible. We know we're professionals. In fact, you don't need a graduate degree. An RN is a professional. They have a bachelor's degree, or they could have an associate's degree. They're still professionals. But the issue is we had this professional and graduate designation before. The problem is what happened now is we had loans. They're called unsubsidized Stafford loans for these graduate degrees. Okay, not just healthcare degrees, lots of different degrees. Those loans, right, they are still in place. They have been given new caps because they removed the PLUS loan. Okay, it's the removal of the PLUS loan that's the problem here. It's not the status, because the status has been what it's been. It now has a new strain on where you're classified because the removal of the PLUS loan. So we had this unsubsidized loan, Stafford loan for graduate degrees. It's always been in place. It's had a cap. Okay, but it didn't matter what the cap was, because what we all did was we went to the PLUS loan, uncapped, unlimited amount of funds. You had to pass a credit check and you got the PLUS loan, right? So it didn't matter if you're professional or graduate, what your degree was, you could get a federal PLUS loan. They got rid of the PLUS loan. So now they said, okay, we're going to take this old designation, professional and graduate, and now we're going to say the professionals get $50,000 a year, $200,000 max lifetime, and the graduate degrees get $20,500 a year, $100,000 max cap. But now there's no workaround, right? We have no workaround. Before, everybody just had this $20,500 and $138,000, I think it was lifetime. Didn't matter because we had the PLUS loan. Nobody cared. So what happened was, so we have this new thing. That's through the One Big Beautiful Bill Act. That's why we're here, right? The One Big Beautiful Bill Act said we're getting rid of PLUS loans. We've got this crisis where people are defaulting on their loans. We can't give these unlimited loans that have, right, just to pass a credit check. We were defaulting like crazy, blah, blah, blah. So we're just going to go back to this original. We have professional degrees, healthcare and not, and we have graduate degrees, healthcare and not. So now professional gets this cap, graduate gets this cap. Okay, Department of Education. Remember we talked about Congress passes a law and funds something? And by the way, that was a saver. So in the One Big Beautiful Bill Act, you have things that cost money, things that save money. That saves money because it's going to reduce the amount of loans and the defaults on those loans. They made a fancy calculation through the CBO, the Congressional Budget Office. It saved money. So it was put into this bill because it helped save money and because it was addressing what this administration thinks is a problem, which is people defaulting on their loans, okay? So now this professional graduate designation is a real problem. The $20,500 a year is not enough. The $100,000 may be enough, maybe not enough. And it's not just for us. Physicians have a problem too, right? If I'm a physician, I'm taking out $300 in loans, and I need $70,000 a year. Well, now I've got a problem too. So again, the problem is the PLUS loan going away. Now the Department of Education is going, okay, we have to figure out, we have to do rulemaking. We have to regulate this. And now we're going to go back and we're going to look at the original definitions and we're going to see how we can finesse or modify, should we, based on what's in the law that Congress just wrote. Do we keep the designations the same as they were, the professional degrees and the graduate degrees? Because now, without the PLUS loans, there is a very new implication. So remember, this was written decades ago, right? We had JDs and we had pharmacists and physicians. They're in the professional category, many others. And then we have us in this graduate category. And nurse practitioners and PAs, which, by the way, is the bigger problem. I mean, from a population health standpoint, nurse practitioners are desperately needed in primary care. Many of them will be not able to get a degree because they can't be capped at that $20,000 a year. So we have the physician problem, NP problem, and PTs now have that problem too. So the Department of Education is going to put out a proposed rule. They've already had a lot of meetings. The way that they make their rules is they gather a lot of experts together, they come to a consensus, and then they put out the proposed rule. All proposed rules that are going to be mandatory when they go into effect, they have to go through notice and comment rulemaking. They're going to put out this proposed rule. I think it only is going to add the Psi D to the original definition. They went very strict with the definition. Now, in that proposed rule, we have to make comments and we have to make a good argument for any professions that think they should be included in the professional cap. If you make a good argument for why, and then there is a chance that they could, to final rule, when they go from proposed rule to final rule based on the comments, they change what they put into that final rule. Regardless, one would argue that we still have a legal problem. We still have an issue, even if certain, let's say a couple of professions get rebucketed into professional, it's still a problem for some professions regardless, because these annual caps aren't very high and there's no alternative solution. The states are very varied. Some states have a decent program, some have a great program, some have very little support. We have private loans, but we still have an issue here. And I would say for therapists, and I wrote about this in my little newsletter too, we're taking out loans that are way too high for us to pay back. I referenced in my newsletter the Money Guy Show, which is a podcast I just think is really fun. I really love personal finance. They have said for years, do not take out more loans that are equal to what you anticipate to make your first year out of school. Well, with that argument, we shouldn't be taking out more than $80,000 or something around that ballpark for the DPT if that's about what we're going to make. And that's supposed to include your undergraduate loans too. So if you have undergraduate loans, subtract that from that amount. And that's how much you should be taking out in loans. That's why we can't pay back our loans. And it all goes back to, yes, our reimbursement's not high enough, but the root problem has to be solved for, because all of this is noise. Our loans are too high regardless if we get them from the federal government or elsewhere. So does that explain, or do you have follow-up questions on the loan issue?
That does explain. And the way that you've put it, I see it because people get really hung up on the term professional and they're like, well, and I'm like, we're focusing on the wrong semantics here. Instead of being called a professional or a graduate, it's more of a finance question. It's more of a finance thing. And it shows that A, we don't understand our own finances, and two, we're not getting reimbursed a ton. So why are we taking out $150 when CMS doesn't see us as a profession to be paid $150,000 a year?
Yeah,
So,
and I would say it's not even that they don't see us as a profession to be paid that much. They have because they take the AMA's recommendations most of the time when they value codes, although this administration for the first time broke away from that for some things. I would argue, and I'm sure some don't agree with me, but I would argue we have not made the case to the people holding the money in their hands. They hold CMS holds the budget. They hold all of the available dollars for the physician fee schedule in their pocketbook. It's their responsibility to distribute their budget that they're given by Congress. So it's not, Congress didn't decide how much to pay us. Congress gives CMS the money to pay every code billed in the physician fee schedule under Medicare Part B. Every other payer bases their rates on the Medicare rates, right? So CMS is the root, right? The genesis of this. Historically, we've had, 10 codes, 12 codes that we use on a regular basis. They valued them at X because the AMA, the Relative Value Unit Committee, they have given us codes to use. They've weighted those codes, and that's how much we're paid. We have to make the argument that the value of our work is very undercompensated, just like primary care. So we make the parallel. You recognize, CMS, that primary care is being underpaid. Therefore, they can't have the impact you want them to have on population health. We are part of primary care. Our codes have not been considered when you have reevaluated the weights of primary care codes. Therefore, A, there should be some additional codes for the coordination and navigation and other work that we do in education, et cetera. And our codes need to be paid higher because we are becoming an unviable profession, highly educated, prepared to be part of primary care and interdisciplinary specialty care teams, but we can't survive. So let us help you solve your problem, reimburse us more, and then, by the way, then we'll be able to pay back the loans that we're strapped with. Because, see, this is the other thing I didn't mention. Part of what the administration has written about this is by capping these loans, universities are going to reduce or they're going to slow down the rate of growth of their tuition. I am very skeptical of this, right? There's ways to get people to pay, right? One of them is you accept more people, and the ones that accept admission are the ones that have the money to pay for it. So you don't end up getting the people most passionate about being physical therapists or nurse practitioners or physicians or pharmacists. You end up getting the people who have been A, accepted, and B, have the money to pay without taking the loans. So if I'm a university, what's my incentive? Keep tuition as high as it can be and accept people that can pay the tuition. Now, I could be off base. Maybe we're going to see some tuition reduction. Has that happened that I don't know about? Because I don't think there's been anything that's caused that to happen. So
Yeah, I've
I don't
never
know.
seen anything.
Maybe, but I'm skeptical that that's going to be the result of this. I think they're misguided in their thinking. Are they misguided in saying we have a problem where people are taking out more than they can pay back? Who's going to argue with that? It's factual. There are people taking out loans that cannot be paid back for the profession that they're getting the degree in. And again, this profession thing is not new. It's just a bucket used by that group to decide what's paid for and how, like how to make these loans structured. It's been in statute since I think it's 1965. I mean, this is not new. We were not removed from professional status. I keep seeing this online. They took nurses and therapists and yada, yada off of professional status. No, they're not saying we're not professions. And we were never in the professional degree category, not forever. So that is getting everyone stuck in seeing the problem, right?
See, it's a great way to reframe your mindset. And also, when you know this is how we've always been valued and looked at, why are we arguing and getting so passionate over, definitions of a word that have always been there? Because you want the validation of being called a professional.
Well, it's not even how we're valued. Remember, when they wrote that, we had a bachelor's degree required. Like, they didn't even have to consider PT because we didn't have even a graduate degree. I don't know, maybe there was, I don't know the timeline for when we had the first master's degrees, but I think it was later than that original statute was in place.
It was like the 90s, I think.
I think honestly. It was, I got my master's in 98. It wasn't even mandatory yet, but there were already doctoral programs at the time. But this profession's been wacky with the degrees. We're finally I agree, the DPT is where we need to be it was a smart move, but we didn't take the other steps, which are we have to be paid like doctors. We can't have a doctoral degree with 3 years. But again, nurses, same thing. They don't have graduate degrees. They have undergraduate degrees. We had undergraduate degrees at the time. The mistake they're making now is not considering when a degree has expanded to ours, it's so obvious we should be in a professional category when it comes to even the loans. But do I agree that our cap should be at $200,000 and $50,000 a year? Absolutely not.
There should be like a middle.
It should be based on your ROI, right? So nurse practitioners, no doubt, they have a 2-year degree. They're paying what? I don't, ballpark, maybe 50 a year. They need more than 100, but more than anything, they need more than $20,500 a year. They're making 120, 130 when they come out of school. They can pay that back. The ROI is there. So they should be, but should they be 200? No, but they should be more than 20,500 a year. So the arbitrary nature of this, all those things we can argue, that has to be addressed at the congressional level. They have given us 2 buckets. That's all we have to work with, right? Congress set that in place. Now, who goes into which bucket for those caps? Unless you go back and a new law is passed, that's how you fix like something like scaling it. But we shouldn't be taking out more loans. But the buckets are insulting by nomenclature, right? And they should have implemented. I'd like to see them implement this in a more nuanced way. But anyway.
Yeah, before we move on, I will say to those who are like, there's no way this can happen. I actually worked for 2 physical therapists in Idaho that one paid $2,000 for his DPT because he applied to like 500 scholarships and he got a bunch and he went to an in-state school that he lived in and also qualified, and he had been working on for years how to qualify for certain things. So I know personally, I've worked for one where he paid less than $5,000 total because he had put in the work to pay for it through scholarships.
That's amazing.
And so I know it's possible. And I also have another one that did it for less than $50,000 because he did everything in state and constantly was applying for the one program that he could get scholarships and grants for. But it took a lot of preemptive work. If you're just, again, in survival mode, and if you're just like, oh, I need a job. Oh, I should be a PT. Let me go apply to a random one that then, it's across the country. I just think we need to slow down, be smarter, know finance principles. And
you're right. Because if you could go without loan or minimal loans, you've saved up for it, or your family can pay, it's going to help you pay for it. Or you go, let's say you go into the military and they pay back, right? You're in a program like that. I don't know how it works exactly, but I know there's ways. Or you go to a rural area and they're willing to pay back your loans. If it's what you truly, genuinely, it's what you feel called to do, there are ways. But if we, again, think about this, we need to educate, especially with all the turnover, we need to educate loads of therapists to meet the demand. And I would hope demand goes way higher because we should be seeing many more patients than we do and accessing them sooner. So the demand should continue to go up. But if you really feel passionate about it and you can get the degree without going into any debt, there are ways to make it still work. The problem is it's just to get enough people in programs and educate enough every year to keep up and to pay these loans. That's part of the challenge, right? And then you have to have no income. If you're going to be full-time in school for 3 years, you're going to have no income. That's another, right? I have a dear friend who just finished medical school, hundreds and hundreds of thousands in loans because she had to also pay for her living expenses through loans. Her only option is to be a specialist because she has to, which she was wanted to be anyway. But as a medical specialist in her residency and, going into the next step, she'll be able to pay these loans back, but only as a specialist, even in medicine. So if you have all your money saved up or someone's paying for you, you still have to be able to have no income for 3 years. It's a lot. And that's I wish I had the answer except to say, if we can do grassroots effort and get the majority of therapists to believe that something different is possible, and we can approach the right stakeholders. That doesn't just include CMS, it also includes employers and other self-funded insurances to say, here's our value, here's the data that shows how our intervention is an investment that pays dividends in reducing other spend and avoiding other spend. We can make progress. We have to change the perception through policymakers and through primary care docs who need to be our advocates, that we're part of their team. I make this argument every time I'm on anybody's podcast, so I have to do it every time I'm on this one too.
Love it. Awesome. So we're kind of transition real quick. There's another model that also came out, and we were talking about accessing more people. I've heard this term access model. What's that? Is that something close to the MAHA thing, or is it totally different?
Yeah. So the access model is another super interesting one. It's been out about a week or so now. The access model is a model created to pay for digital health. I don't mean telehealth, right? Difference. Digital health and telehealth are two different things. Pay for digital health because we have a lot of new novel ways of engaging beneficiaries, which is a big tenet, a strategy that this CMS led by Dr. Oz really believes that if we can engage beneficiaries in ways they're used to, like using their own devices and wearables and other things, apps, then we can get them engaged in a natural way. So it is a tool to help them manage and change the trajectory of their chronic disease, prevent chronic disease, et cetera, right? No billing codes for these tools. So if you have you implement a program and every day you're sent a short educational video and a little task to do on your smartphone, you have no way to build a physician fee schedule for something like this. But there are many who believe that there's efficacy behind it. So these companies have no good reimbursement mechanism for Medicare beneficiaries. There's a big push for the health tech ecosystem in this administration, commitments industry's making, and digital health is one of the levers that they want to see if they can pull. Digital health, again, has no reimbursement mechanism. So this model essentially is going to provide accepted organizations what they're calling an outcomes aligned payment. So it's a payment that will, all the details are not out yet, but it'll be a monthly payment paid to the access organization to provide a set of services, very flexible what those could be, including digital health as part of the solution. And the amount that they'll be paid will be modulated based on the actual data that comes out of the results of using this digital tech. So, for example, let's say there's different tracks, different types of conditions. So one is cardiometabolic, an earlier and a late stage. So let's say the earlier stage cardiometabolic, blood pressure control is going to be one of the things that they look at. Blood pressure, it's going to be very individual, what's considered to be improvement for the different objective measures. They have to be collectible, like easy to collect measures that they're going to, right, share what they are. It might be just 10 millimeters of mercury that someone's blood pressure has to be dropped over time, and then the access org will be given them the maximum payment, for example. I think everyone's expectations should be very controlled as to what this monthly payment's going to be. We don't know this, but I suspect it's going to be the kind of payment that assumes most of the work is done through automation, through the technology itself. We're not talking about like a capitated payment to provide therapy. That's not what this is, right? This is not a replacement for traditional medical care. It is a payment to allow digital health to have a reimbursement mechanism and to show over time through the data collected that there is a noticeable real impact on data considered standard for demonstrating, health or lack thereof. So one of the ways they show as an example is like, let's say you have an access org, which has to be a Medicare Part B provider. You can apply to be one. If you're not, has to have a medical director and then has to have some product, right, that they design. Maybe it's already in place. A lot of who has shown interest are digital tech companies. So think like Omada and Whoop and Aura and things like that, right? They're going to get paid for a monthly utilization. Primary care docs and other clinicians, they have to be physicians and APPs, I believe. They can bill a co-management code to work with the access org for their patients. So they can refer their patients, like I'm Dr. Smith, I'm a PCP, my patient with diabetes or cardiometabolic disease or low back pain, I want them to engage in a digital health tool. They're not just going to pay for it out of their pocket. I'm going to refer them to the access organization. I'm going to look on the website. Oh, look, this access org has the best outcomes. I am going to work with that provider. I'm going to refer my patient to that access org. They're going to implement their tech strategy, whatever it is, their engagement strategy, they're mandated to send me all the data back about how my patient's doing. And I then get to bill, it's like about $100 a year per beneficiary that you refer to an access org and they're engaged in that access org.
Gotcha.
So it's not, I don't see this as like a primary care. They're not going to be the ones that are going to be access orgs. I think it's going to be other types of groups that are provider enabled, like they have to have a provider and a physician that's a director that's kind of making sure it's medically appropriate, evidence-based, right? So again, that's what it is. It's a digital health payment tool for all intents and purposes.
Into RTM at all, or do you ever foresee that maybe this could affect how RTM is even looked at?
I do. We have to see where, and it may be in one of the detailed, there's some technical FAQs they put out that I haven't totally read through, but I would look at some tea leaves here on RTM and RPM. One of the insurers has said they're not going to pay for RPM anymore as a billing code. So that's physiologic monitoring. So that's things like blood pressure, cuffs, and weight and other, right? Physiologic monitoring. RTM is just the cousin of RPM, right? So if there's a digital health payment structure now, right, that you could imagine a world where RTM and RPM are bucketed into digital health. I'd really have to look at, to answer this fully, the definition, if RTM falls into digital health or it's considered a more telehealth. I would think it's digital health. But again, I'm speaking a bit out of turn. But yes, I would think about things like this. Like, we could just have payers say, well, we're going to not cover the RTM codes anymore. CMS has them in place. And so as long as CMS has them in place, Medicare is going to continue to pay for RTM. They just gave that additional code for fewer minutes. So I don't know that that's something that we're going to see go away anytime soon. But, it's something to keep on radar for sure.
Perfect. Okay, that's just good because I know a lot of people, RTM is a big
it is
revenue increaser. So it's just something to keep aware of.
But see, and that's the word you used. It's a revenue increaser. And that's just a gut reaction because that's what we hear all the time. That's the problem, though, because if we want to change how we're viewed, I would say we should be speaking about RTM as an additional tool. Yeah, say it again.
As outcome improvement, not a revenue increase.
It's another lever to pull to help facilitate the best outcomes by engaging patients in different ways, right? We have remote therapeutic monitoring. So we have an additional way to engage patients in their care and their treatment plan that, oh, by the way, could go beyond when we transition them off of regular physical therapy care. There's lots of ways to think about RTM. But when we just think about it as a reimbursement mechanism and don't think about how it's a puzzle piece in a treatment plan, we set ourselves up for showing that everything they give us is a widget and becomes a commodity, just something that we look to maximize billing on. That's exactly why they don't want to create more billing codes for digital health, because they know from experience, whenever you create a code, everyone's going to use it as much as they possibly can because it's a widget. It's something that they can bill and get paid for. So instead of putting out more billing codes for digital tech, they're creating a code where the payment is based on the outcome. And if you're very efficient and you can scale it, you'll be able to make some profit. But I don't think it's going to be so easy, straightforward. I think it's something therapists must be involved in to some degree, whether it's making sure they get the information. If there's an access org in their area, they're managing a patient with low back pain, they should probably be referring their patients. So if you're involved with one or you create one and you have tech that you partner with and a medical director, maybe that's something therapists should consider. I'm not saying it's going to be like RTM. I can count how many times I can bill that code. That's not the purpose of this. It's got to be a way to show the best outcomes, show that it's another tool to manage a condition like chronic low back pain, and that there's a result that you're going to get from it. And by the way, they're going to make all this public. So they're going to put all the data up about the access orgs, and they're going to show this access org treating musculoskeletal pain has this score in their PROM and this one has this score. So it's transparency all the way, right? So
Wow.
again, just
Yeah.
realizing what are they trying to solve for here? We like transparency, right? We like competition. We like finding the most efficient solutions, things that can scale, right? Innovation. These are forward in the CMS. I'm not interpreting. I'm just reading and telling you what I'm reading, right? It's being said over and over again on CMS blogs. Don't underestimate the value of reading the blogs at CMS and the Innovation Center and the videos they're putting out. They're telling you what you should know. You just have to think about, like, what does this mean?
Awesome. I love that. Last question. So we're kind of in the tail end of 25. Has there been a Medicare or a CMS 26 final rule proposed at all?
The physician fee schedule final rule came out, and some of the highlights, right? They put in an efficiency adjustment. So that's to put an efficiency adjustment and a change in work reviews. So just let's kind of look at what they did generally. The term site neutral payments, if anyone's not familiar with them, site neutral payment is the concept that a payer should be paying the same amount for a service regardless of where that service is delivered. So in practicality, what that means is for a physician or a health system owned practice of any kind, right? CMS pays more for a service being delivered when a health system owns a practice versus when it's an independent practice. And it's a big difference in the amount. So what CMS did was they said, we are going to make an adjustment and we're going to reduce the amount of difference between care provided by a health system owned practice of any kind. I'm not speaking PT specifically, practice of any kind. And we're going to reduce that difference so that we're not paying quite as much of this overpayment when a health system happens to own. So, the proliferation of physician clinics owned by hospitals of all kinds, right? That's been a big problem in the physician fee schedule because they're having to pay all of this additional money. So they're clawing back some of this. And then they also made an efficiency adjustment on, we were talking about this before, on specialists. So it's just impacting mostly specialists that are non-time based. So what they said was, okay, you guys are doing all these, let's say orthopedics, doing all these surgeries. We do AMA does a survey every year. They send this survey out to docs. The docs answer this survey. And then based upon what surgeons are telling us and interventional docs are telling us is how efficient they are, that's how we determine how much efficiency we should assign to a code. So just broadly speaking about this, right? So what they're saying is we don't agree anymore that what is being reported on these limited surveys that are coming into the AMA, we're not going to go by that anymore. We are going to assume, and we've done in research, whatever they've done to make this conclusion, we believe technology has improved significantly. And the things that we're paying for, we're assuming they're taking more time than they actually are. There's lots of ways where technology has made you more efficient. So we are going to start paying less for things that we believe don't require the time that we've historically heard it takes to do these things. We think you're more efficient. So we're going to start adjusting down your reimbursement. So the value of the weight of your codes, which remember, all codes get multiplied by the conversion factor. We're going to reduce some of these. We're going to reduce the weight of these codes, and we're going to take that reduction and we have to spread that elsewhere, right? We're going to give it to primary care for the most part. Primary care, a little behavioral health. That's where they shifted. So remember, physician fee schedule is a bucket of money. That's it. It's a bucket of money. They have to figure out where it goes. They have to distribute it across everybody that bills. So if they giving less to specialists that provide interventions, at least per service, then they can take those dollars and redistribute them by weighting other providers and clinicians' codes more heavily. So primary care and behavioral health were the major beneficiaries of that shift. Specialists received, especially interventionalists, especially those owned by hospitals, because they already got that reduction. They got significant reductions this year. Again, if I'm a physical therapist, I'm watching primary care, benefit. We take from Peter to pay Paul. We're taking from specialists to pay primary care. We're taking from specialists to pay behavioral health. We're not taking from specialists to pay physical occupational speech therapy. We didn't get anything from that. We didn't get anything from that. So those are the arguments. I would go back. If this is my job, it's not my day job. If this was my job and I was advocating for therapists, I would be going to them and saying, we need to be the beneficiaries of this. And here's why. And not because it can't be all about us. It's because here's how we can solve for the problems that you're actively trying to solve for. But we are heavily under-resourced. So if you reimburse us more, we can provide much more access to care, continue to provide our high-value care, right? And be a part of your solution. But anyway, so that's the vision fee schedule, big highlight. There's an ambulatory specialty mandatory model. It's going to affect heart failure and low back pain. 25% of the specialist physicians in the country are going to be impacted by this. It's up to 12% downside risk over the course of the model. Now, it's regional, so it'll be all the physicians are going to kind of be competing against each other in terms of how better the quality and improvement in cost will be. And so you would imagine, right, all the different physicians that are managing low back pain, they need alternatives that are high quality, high efficacy, and lower cost to help manage their low back pain patients rather than surgeries, injections, imaging, the things that are going to show up when you look at the regional spend. If I keep doing what I'm doing, surgeries, interventions, imaging, etc., I'm going to be higher cost than my region, and I am going to end up getting a cut. I'm going to get penalized for that. I see this as an opportunity. As soon as we know the regions this is going to be in, if I'm a PT clinic, I'm going to everybody who manages low back pain, all the physicians in my area, and telling them how I can help them not be penalized in this model we're talking a nice chunk that they can be penalized financially on an annual basis. I'm looking at this as a huge opportunity to partner with a variety of different medical specialists. So we have that. One last thing, I know we're way over time, but I want to point to something in the outpatient payment system, the OPPS final rule. The most important thing in there is the abolishment of the inpatient-only list. Fun history here, right? At the end of the first Trump administration, under that HHS, they ended the inpatient-only list at the very tail end of the administration. Inpatient-only list is a list of, it's like close to 2,000 procedures that can only be done once you're admitted to the hospital. So you must be an inpatient patient admitted to the hospital, cannot be done in any other setting. Only Medicare does this. No other payer says there are certain conditions where we're only going to let you do it inpatient. Okay. They do this at the end of the Trump administration. Biden administration comes in and they said, nope, we're not doing that. We're going to put them all back on. And so it was like whiplash, right? That administrations can do that if something is finalized at the very tail end of an administration before there's a changeover in the president, they can retract some things. So they retracted it. Biden retracted it. So Trump comes back in. We all assumed this would happen, the ones of us who were tracking this. So again, they removed the inpatient-only list. They're doing it over 3 years. For 2026, it's almost entirely musculoskeletal procedures. So now they're saying they can be done in the outpatient department, hospital outpatient department, and many of them were also moved to ambulatory surgery centers. What does this incentivize, right? We know when hips and knees were removed from the inpatient-only list as one-offs, it only took a couple of years till the vast majority are done in an outpatient center and some in ambulatory surgery. So that's going to happen. Physicians are going to they're going to decide themselves if it needs to be done. If not, they're going to find ways, if it's more efficient for them and it's safe, they'll do it on an outpatient basis. It's going to reduce volume to hospitals. It's going to reduce who qualifies for skilled nursing facilities because they're not going to have inpatient stays. And if I'm a PT, I'm looking at what opportunity is this for me? These are coming off. What am I planning for? Who am I in the health system? Who am I in the care continuum? Do I work for an inpatient rehab or a home health or an outpatient that goes to the home or SNF, whatever? And what does this mean for me? What is the market changing How am I adapting? Is this a risk or an opportunity or both? What does it mean for my business? Like, these are the things everybody should be thinking about. And the TM model, we know that's the other thing. That was the inpatient payment system. That was finalized and made a couple of updates, but we got 25% of hospitals mandated into this bundled program. I don't hear a heck of a lot of talk about it, but it's, again, there's opportunities and risks depending on where you work that we should be thinking about. So,
yeah, well, so much to think about. Well, Dana, thanks for coming on, and I'm sure we'll have more questions as things roll out and change. So,
thanks for listening to another episode of Strata Stories. Strata PT combines your EMR and billing into one automated system to increase revenue and achieve a 99.99% reimbursement rate for physical, occupational, and speech therapy clinics. If you'd like to learn more about Strata PT and see how our EMR and billing services work, head over to stratapt.com to book a demo.